Welcome everyone to today's webinar. I am Margo Vaselli with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. We are pleased to have Scott Becker, publisher of Becker's Healthcare, here to moderate today's question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about 2 weeks following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Dr. Tamara Cull currently serves as Vice President of Market Development for MedDecision. Prior to her role at MedDecision, Dr. Cull served as National Director of Population Health Account Management for Catholic Health Initiatives with leadership responsibility for value-based programs and operations. Dr. Cull also serves as adjunct faculty for the MHA program for the University of Arkansas, Fort Smith, teaching health policy and organizational behavior courses. Dr. Cull and MedDecision will be at the Becker's Hospital Review 8th Annual Meeting in April and are available to meet with those interested in learning more. Dr. Cull, I'll now turn the floor over to you.
Thank you so much, Margo, and I appreciate everybody's attendance today as we talk about achieving AAA success in bundle payment models. So we'll go ahead and get started to make good use of our time together. So on the next slide, we'll just level set here on the items that we plan to discuss today as we get started. So the purpose of the webinar today is to review opportunities within episode or bundle payment models. We'll also talk about research that focuses on these models of care and the outcomes that teams have been achieving with these models. And then look at how to optimize revenue from bundle payments, increase compliance by utilizing evidence-based care plans, and talk through opportunities for automation and technologies that are available. So as we look at the opportunities on slide 4, we're going to dive right in to some of the key facts, the level set where we plan to focus our time today on some of the facts about bundle payments. So as we focus our attention today, we'll talk primarily about Medicare bundle payments, but I'll also weave in some comments about commercial bundles as well as we go along with our time together today. So to start out here, just level setting here that Medicare has a goal, of course, around increasing the use of value-based programs across the country, and started this work now with their first voluntary bundle program launching in October of 2013. So it's already 2017. Medicare's been at this work now for several years, so we do have some evidence that we're starting to see published that we'll talk about today. But as Medicare has been pushing toward value, so have other payers. And what we're seeing from Medicare is a desire to have more multi-payer models. So they truly want to have other payers join them on this value journey. And so as they have released the most recent models out of the Medicare Innovation Center, we're actually seeing them partner with other payers in the launching of those models. We do know that Medicare has already announced plans for a voluntary bundle payment program version 2, which has not been named yet, but they do plan to launch that program in 2018 and already are starting to talk about what that might look like. And so I'll cover some of that today as I offer my comments about these models. As Medicare has moved along on the journey, starting in that voluntary space, they quickly moved into the mandatory space and launched the Comprehensive Care for Joint Replacement program. Some people on the line may be having the opportunity to participate in that program, as over 800 hospitals were picked to work with Medicare on total joint replacement. And so that was Medicare's first mandatory program. And then on the heels of that, announcing that they do plan to now expand mandatory bundle payment and move into cardiac areas of focus with the launching of the episode payment model, which will include over 1,100 hospitals across the country. And the launching date for that is still firm in the latest communication as a go-live date of July 1st of 2017. So clearly Medicare is on a journey toward value. Clearly they feel like bundles are helping them achieve their results. And so this path that they set forward way back in 2012 when I started working with the Innovation Center on these models is clearly the path that they plan to continue. So today we'll focus in on what Medicare has done and some key successes that teams have achieved within this model to try to help you on your journey with bundle payments. So on the next slide, I want to talk through some of the key details here, again, just so that we're all on the same page as to what we need to focus in on as we're doing this work. So I just mentioned the payers. Medicare is our largest payer that is doing this work, but certainly state Medicaid programs have been highly engaged in episodes of care. And in the state that you're located in, you may be seeing this activity already, or you may see it in the near future as Medicaid providers definitely starting to engage physicians around bundles of care. So this has definitely increased since 2013 as well and continues to escalate. And then we're starting, of course, to see some of the larger commercial payers and even some employers come into this space and approach health systems or integrated delivery networks that are doing this work to partner with them on episodes of care. So definitely the payer landscape is changing as this work has proven successful. The design of the episode-based payment models are truly consistent around being designed around a clinical episode of care. So a DRG if you're a clinician, but you know, the focus area here is that Medicare and other payers are picking clinical areas of care that they feel like have an opportunity for care redesign to improve their efforts, and that's where they're focusing in to do these models, and we'll talk a little bit about how that care redesign works. The length of the episode has been fairly consistent. Medicare has held firm that as they've gone from voluntary bundles now into mandatory bundles, that they feel like the 90-day episode of care is the one that is working consistently the best. So you see that they have continued that length of episode in their models, meaning that day one starts on the day that a patient is admitted to the hospital with that clinical episode of care, and then goes 90 days after discharge from the hospital. So I think Medicare, again, now they have launched 2 mandatory bundles and designed 2 mandatory bundles that have a 90-day episode of care. So I think that is going to hold firm with the way they design these value-based models. The accountability is shifting. So this is a topic that I'll talk about some today because it's been highly debated at the Innovation Center and with other interest groups. Who should be accountable with Medicare for this kind of work? In the mandatory bundles, Medicare was very clear that this is a hospital accountable bundle, and the hospital itself will be held accountable for entering into an agreement for this 90-day episode of care. In the voluntary bundles and the bundle payment program, Medicare allowed hospitals to be accountable. They allowed post-acute providers to be accountable, physicians could be accountable, there could be conveners. So there was a much more complex and openness to accountability in the voluntary bundle. So of course, one of the questions that a lot of people are debating currently is what will the accountability look like as Medicare launches the next voluntary bundle payment program? Will we see physicians on the list as accountable parties again? And what will that look like? And all experts are feeling consistent that we will see physician accountability come back to voluntary bundles, as Medicare has heard clearly from the physician groups that they feel like they have a voice here and they have expertise here and they want to be a part of this work. So I think we'll see some of that accountability addressed. The risk model is an up and downside financial risk model. So certainly teams can achieve savings in this model, and I'll talk with you about those areas for savings. But there is a downside financial risk in these programs. So for this 90-day episode of care, it is not without financial risk to teams that are being held accountable. So Medicare tried to address that risk by delaying the starting of financial risk in some of the mandatory models for the first year to allow teams to get their feet under them. These are very complex models, and Medicare has realized that. They've heard loudly from people that are doing this work that teams need a chance to build up their capacity to be successful. And so we did see Medicare express that in delaying some of the financial risk. The opportunities for savings are really twofold in these programs, and I'll talk about both of these today. Certainly, if the team is able to come under the predetermined target price that the payer sets, then you can achieve savings in the model. What we see from teams across the country is that there also is a very large opportunity for internal cost savings in these programs, coming from the redesign of care that is inherent in being successful in this work. So those internal cost savings for some of the teams, especially in the beginning, are very large and sometimes even larger than the payer savings. So I'll draw your attention to some of those as we go through our time together today. These are highly complex programs. If you have responsibility for leadership of these programs, or you are operators inside these programs, you are quickly learning that the need for subject matter experts and possibly consulting to understand the model itself, to understand the program rules and regulations are critical to your success. And so a lot of teams certainly have had to reach out for some expertise as they start these models of care and lean on others that can help guide them as they create their best practice models. So on the next slide, we'll get into where we'll spend a lot of time in our time together, because certainly we want to be focused in here on what is the goal, what is Medicare really after here. We need to level set ourselves on what Medicare is asking of us. And so I want to be clear on the goal, and then we'll spend quite a bit of time talking about program challenges. So Medicare's goal, just republished recently in the report to teams that are participating in the voluntary bundle payment model. And Medicare's been clear about this goal from day one. They have never tried to hide this goal from the teams. It's never been secret. The goal from day one was to test whether linking payments for all providers involved in delivering an episode of care can reduce Medicare costs while maintaining or improving quality of care. So I'll share with you some research that the Innovation Center did around this goal. And the research was focused in on the ability of this model to reduce costs while not impacting quality. And truly from the beginning, that was where the debate was. Can we actually reduce costs by having providers all work together to redesign care without decreasing quality? And we have been able to show that, and I'll give you some specifics about that today. So on the next slide, we'll spend a lot of time here talking about alignment challenges, because this is really the heart of this program. and really where I think I want to spend time giving you some lessons learned here from someone that's been at this since 2012. So certainly as you get into value-based payments and you move away from a fee-for-service environment, you start to immediately experience challenges. So I've highlighted some here that I want to call out to you and talk about today to give you some guidance of where to focus in if you already are involved in bundles or you plan to be involved in bundles, hopefully saving you a little bit of time here on some lessons learned. So of course, we start here with physician expectations. Not a surprise to teams on the line. This program is a clinical program, and yes, there are financial implications, but what the teams are being asked to do is do a clinical redesign. So as you are pulling your groups together to start working with your physicians and your operation teams on how do we redesign care, your physicians have to lead that program. They have to be at the table, they have to be engaged, and you need to very quickly designate who are your high-performing physicians that are willing to serve as partners in this work. And you really do truly need partner physicians. That does not mean you have to employ all of your physicians, but you really need strong partners in this work as your team goes about the business of doing their care redesign. One thing I would mention to you here is what we saw some of the early teams do if they were going to focus in, for example, on orthopedics and joint replacement, is they would have orthopedic surgeons leading all of their teams. But what we found is that, all providers that are working inside the episode of care have something to offer here as you redesign your care. And sometimes, quite honestly, other providers will be your biggest champions as you start to do this work. So keep that in mind as you build your teams and you start to engage them. I would say some key strategies around physician engagement that I'll call out here. Certainly consider what financial incentives you may want to deploy as you do this work. Do you want to engage in a gain sharing of savings program with your physicians that are helping you in the episode of care? What does that look like? I would definitely think about that. For those of you that have physicians that are employed, I would absolutely tell you that on day one, you should start redesigning your incentive plans to be focused on value versus focused on volume. So if you have incentive plans currently that are RVU type focused, you need to move away from that and move into a value model as you look at financial incentives in this work. And then certainly think about integration strategies and network development. You may find as you start to work in a particular clinical episode of care that you have some really strong physician champions that you're seeing participate in this model, and they are not typically members at your table, and you may need to reach out and start to engage them differently. So consider your circle and realize that you may have to widen it to be successful in this physician expectation space. And certainly, I think you'll find yourself more successful from day one if you keep those things in mind as you start to design your model. Certainly, this program is designed around multidisciplinary teams, and the focus of those teams will really be critical to your success. And so typically hospital health system teams, where I've spent 25 years, are focused on what happens inside the hospital. And they are not focused on managing patients outside the walls of the hospital. They are not focused on proactively engaging patients at the lowest acuity settings. So retraining the team, refocusing the team, will be really important in the beginning. Having them clearly understand what an episode of care is and what the goals are will be critical to their success. We really have to stop thinking about encounters with patients and start thinking about a full continuum of care. It's really, really important that your team starts to understand that they are now being held accountable for what happens preoperatively. If it's a surgical episode of care, can impact everything that happens the 90 days after discharge. So starting to retrain teams on the ability to work in a continuum of care is really important. And in your care management teams, I come from the care management field, and they are going to be critical to your success, but they will need to be retrained how to do continuum of care work. Most hospital care managers are not accustomed to this model of care, so you will have to readjust their focuses and the tools that they utilize and how they are able to help patients move along this continuum of care. Keeping in mind always that these programs are not in a vacuum, so we know that these patients will continue to have social determinant of health factors that are important for our teams to keep them in focus. And the teams are really, the navigator, the care manager, whatever title you assign to the person that will be helping to guide these patients through this 90-day continuum, are really going to be seen more as the care traffic controller. So the person that has their eye on this patient along the entire journey and is the one person that at all times knows how the patient is progressing. So it's really key to your success. So I'll call that out as a possible retraining activity that you'll need to do early on. Of course, in this model, there is a financial downside risk. So you definitely, from day one, are going to want to focus your team on how to address that risk and where is the risk for your team. So certainly in this model, you will continue, as all of us do, to focus on improving quality, improving patient satisfaction, and giving the best clinical care you can. So those are things that we do today. Those are not going to change in this model. But as we move toward value and we move toward a financial risk, we have to start thinking about our stability as an organization and how do we need to balance our investments in this model. Where do we need to invest? What will be our critical success factors around staffing, around tools for those staff, and how much can we invest early, when to invest. The strategic plan is something that consultants and subject matter experts are high value to help you with as you start to plot out your strategy for these financial investments and the risk that you will be undertaking as part of this model. Of course, remember that in the patient engagement and activation that you will continue, as you do today, to utilize a relationship building approach with your patients. It will be much more intense of a relationship and it will last a lot longer. So your teams currently today connect with patients, create a relationship, set up a care plan, and they help them as they work towards success in that care plan. The care plan will be longer. It will be across a 90-day continuum of care, but you will still be focusing in on relationships and care plans and creating a circle of influence and a partnership with your patients that are in the program. So those skills are critical as you move ahead. And in that area of patient engagement and activation, you need to make sure that you are remembering that this model will suddenly force you to create, if you don't already have them, post-acute partnerships. So post-acute partnerships and the development of some sort of preferred partner network is critical in order to manage these continuums of care. So certainly the highest successful teams that have had the highest savings have spent a lot of time in creating these partnerships. And when I say partnerships, I don't necessarily mean financial partnerships. I mean a partnership where you reach out to post-acute providers and you ask them to come to the table with you and help you redesign your care for these patients. And you start to create a shared vision. You start to create an accountability matrix of what your partners are willing to do for you and what you're willing to do for your partners. So Medicare is pushing us and other payers to get outside of the hospital again and work with your post-acute partners. So I really want to call that out as a place to spend time. And then lastly, I think it's often overlooked and often assumed that your executive C-suite will have the leadership skills in their toolbox today to help teams succeed in this work. What clearly we have seen is that health system leaders need highly developed skills for change management and cultural transformation if you are moving into value-based payment models. They need to be champions of change. They need to be willing to focus on a population versus one patient at a time. And they need to embrace the value model. So C-suite leadership skills and retraining is definitely an area that we've seen health systems focus in on as they move into these models to help the operation teams that are doing the heavy lifting in the care redesign and touching the patients be successful. So I want to call that out as an area to focus. The team needs to have clear leadership vision around this program. That vision needs to be communicated often, and everyone needs to have incentives that are tied to this value model. So again, it's possible that you have a leadership incentive model that does not align to value. It still aligns to volume. And so I encourage you to take a look at your C-suite and see where there might be opportunities there. So alignment challenges, there's probably about 100 more I could list here, but I would encourage you to start in these large buckets and start to work here on improving those areas. So in the next slide, we'll get into talking a little bit about how you can be successful in managing your data and your tools that you could utilize here in this space. One thing that Medicare promised in this model is that they would provide data, and they do. They give you a lot of historical and ongoing data that is designed to give you insights to how your population is progressing across that 90-day continuum of care. It is intended to give you vision into focus areas. Unfortunately, the data is very complex. It doesn't come to you in an easy-to-use, off the Excel spreadsheet, pop it in and you're ready to go. So data is really important as you move into this work to give you a navigation of the program. So they will give you data in the beginning of the model to let you know where you're doing well and where you have the most opportunities for change. So I encourage you to invest in tools to help you and likely subject matter experts to help you understand what the data is telling you. Because certainly you don't want to spend time on care redesign in areas of the continuum that you're doing well in. You want to spend time in redesigning care where you have opportunities. So for example, when you receive your historical data, if you realize that you have an opportunity for decreasing your skilled nursing facility utilization, then that's where your team might want to start versus if you feel like you have an opportunity in driving down hospital length of stay, but as you look at your data, you see that work's already been accomplished and you've already had a decline steadily in that area of the continuum. So use your data to design your program. That's really what it's intended for, and that's why Medicare gives you the historical data, is so that you can really narrow your focus, because trying to create a care redesign model is complex. So they're trying to give you some focus areas here. So use it for that possibility of where to centralize your teams. The other thing I would say about surgical episodes of care that we've seen proven very successful across the country is when you have a surgical episode of care, building in some preoperative optimization components. So not always possible in some surgical episodes, but for the knee and hip replacement, highly successful, building in some preoperative education, some preoperative assessments to make sure that patients are in the best clinical condition to go to surgery, and working on some of those areas before the episode kicks off, really key to success if you have the opportunity in your surgical program. So think about that as you're doing your program design. As you move into operations and you have a team and you're ready to start doing operations, truly the most successful teams have adopted a standardized care path, and this will speak to all of us who are in health systems for years, mapping out workflows that are specific to that clinical episode of care. That's really important, that you give a team to redesign and really challenge your teams to create something different than what you have today. Even if what you have today is working, we really want to innovate in this model. That's really what Medicare is asking you to do, is to do things differently than what you did before. So challenge your teams to do that work as they go about redesigning care. Make sure that you give your teams tools that will allow them to see a full continuum of care pathway and be able to navigate that pathway. That'll be critical to their success, and they'll need to have an ability to prioritize patients who are at the highest risk, remembering that some of these episodes of care are high volume for some health systems. So in the joint replacement program, for example, there are some teams that have over 100 of these patients a month that they're trying to navigate. So how do you prioritize which of those 100 need your attention? So giving your team tools for that and the ability to track against that care continuum. And then make sure when your program is operational that you're continuing to monitor the Medicare or other payer data for trends and watch those trends. So as you make a change in your program, see how it impacts the program positively or negatively, and course correct in real time if you can, so that you don't have a lag in program success. And then making sure, number 3, that your program insights and modifications, that your team is following those clearly on track as a team to what you are asking them to do, and remembering that this is not a static model. Once you operationalize this model, it will not be the model that stays in place for the entirety of the program. This is a change model. This is innovation. So know that you will have to continue to make changes, sometimes on a weekly, monthly basis, to get the care model where it needs to be. And then I would not I want teams to understand that as you're doing this work, your compliance and quality teams need to be engaged in what you're doing and need to be partners as you're doing this work, because clearly there are requirements in these areas, and Medicare is pretty specific about what you can and cannot do and what you have to track and report on. So just make sure from day one, don't add quality and compliance as an afterthought. Make sure that they're there at the table early on as you're designing your programs. So on the next slide, I want to zero in on where teams have found the most opportunity for cost reduction. And there's really three areas that stand out in my work with health teams that are doing this and also in the research. Certainly readmissions is something that teams have had success with in this model. I'll show you some research which is connected to decreasing readmissions, but in one health system I worked with, there was a 46% reduction in the first year of the program just by doing a care redesign around joint replacement. So certainly there is a huge opportunity around readmissions as you start to do things differently in surgical episodes, as you start to do a preoperative optimization. You'll see a very fast-paced reduction often in readmissions. Where most of us have been highly successful and where you hear most of the press release is around decreasing post-acute utilization. And I want to be clear here about this because I think if you're a post-acute provider, what people immediately say is that means no one gets to experience post-acute care. And this could be home health, it could be skilled nursing, rehab, whatever it is. That's certainly not what research and actual teams are telling us about this model. It truly has been in two areas, this decrease in utilization. One is around going to a post-acute provider during the episode of care. So certainly some of it is utilization. And one of the health systems I worked with had a 45% decrease in just SNF utilization alone. The patients that before the program started went to SNF and then after the program did not go to SNF as part of the new care program. So that is one side of decreasing utilization. But I would say most of the teams have reported as much success or more success around decreasing the length of stay of the utilization, whether it's SNF or home health or rehab. If they're going to that level of care and before the program they stayed 20 days and now after the program they're only staying 10, that impacts the continuum of care. It impacts the episode. And so certainly we've seen a lot of teams not avoid post-acute care completely, but work more toward preferred partnerships that will drive down that length of stay. And you'll see here some of the teams, clearly a lot of teams across the country have had more than a 50% decrease in length of stay in these levels of care. So that is definitely an area I would encourage you to start working with your partners on and identifying which partners are willing to change the way they deliver care in this model to help you achieve these results. And then I mentioned earlier in the presentation about internal cost savings. Again, I'll call it out to you. I think teams don't spend enough time here looking at areas inside the walls of the hospital that they can decrease costs. A lot of health systems have already had very intense programs around decreasing internal costs, and so we often think that we've done everything we can do, but clearly the teams I've worked with, they found clear opportunities still in the area of internal costs. And so I want to call that out as an opportunity. And so on the next slide, we'll start to focus in here and move toward the research, because certainly I think it's great for me to tell you about health systems that have had success in achieving triple aim results, but I want you to see the research. So I highlight two research opportunities here for you to reflect on as you're starting to redesign your care. The Innovation Center, so Centers for Medicare and Medicaid Innovation, who are accountable for these models, released this recently in the fall, September, and this was their first research that was released on bundle payment. So it was highly anticipated. Everyone was waiting to see them release research, and so this is the first one. You see the article there. for your reference. And so, again, remembering what the CMS goal was that I quoted you in the beginning, that's exactly how they set up this research project, is to see if they were able to decrease costs without impacting quality. And what they found clearly, they looked at 176 hospitals, is that the results were very clear in this research and other research that's out there that you can certainly look into, is that in this model of episodes, the teams that were in the model that were being held accountable for a 90-day episode of care were able to decrease costs. So on average, you're seeing here $1,166 of a reduction over the group that was not in bundle payment. But we've seen even higher, and I'll show you some higher results. So cost savings in the model has been now proven several times, but this is the official Medicare research, so I wanted you to have it. They, of course, wanted to put that up against quality and see if it impacted quality, and it did not impact quality. And you see how they define quality by looking, no surprise, looking at the standard Medicare metrics for readmissions, emergency room visits, and mortality. And it did not show any impact. And so this is really the research article that is now being quoted to the new administration to say we can decrease costs by using these models without an impact to quality, because that's truly what a lot of opponents of the model were saying. So clearly now research out there saying that did not happen in this model. On the next slide, you'll see research that I completed as part of my dissertation work at, and truly what I want to point out here about this research study that was with Catholic Health Initiative that you heard in my introduction, the same thing. What we could see as we did our research is, and you'll see here, we actually had episode reduction costs of $3,333. So higher on average. Some of our teams were much higher than $3,000. Some of them were lower than that. So there's an average of the 4 hospitals that we researched. But clearly what we could see as we were doing our work is that cost savings was there. You'll see that in several research articles. What we're having more difficulty proving is, can we reduce readmissions? Scientifically proven, can we reduce readmissions? And you'll see here that we were very close to proving that in my research here, and certainly I think if we redid it, we probably could prove it for these hospitals with more episodes loaded. But clearly what we did see, and Medicare does not want teams that are engaging in episode models to research, is patient satisfaction. So at Catholic Health Initiatives, we did monitor patient satisfaction as part of our model. And what we found is that patient satisfaction was improving. So was physician satisfaction. So the providers that were engaged in this work clearly more satisfied. So there's research that I'm sure we'll see more and more research, but as you look at the triple aim and you look toward improving your patient and provider satisfaction and look toward improving quality and decreasing costs, there's truly enough research out there now, since teams have been doing this work since 2013, to show that these models are being successful in those areas. So as I wrap up, on slide 14, I want to focus in here on the work that MedDecision is doing around episodes of care and our journey that we're helping our customers with in this work. So as MedDecision looks at the critical elements of successful population health, we know from our 30 years in this business that there's 4 critical areas to get teams to success. So definitely the alignment, and I talked a lot today about gaining alignment, and then using the data. So how do you harness the power of this data, and how do you use that to prioritize your work? And then you definitely have to zero in there and target your opportunities for cost reduction. And remember that you won't be able to do everything on day one. So make sure you have a prioritization plan. And then, of course, in all of these programs, number 4, we'll want to keep the teams focused in on how to measure, monitor, and report your quality and performance. So on the next page, I want to just highlight to you our new Bundled Episode Manager application designed specifically for this space to optimize revenue from bundle payment and increase your compliance. And it's focused in on a model around care plans, because our teams clearly know from the experience in this model that we have to focus in on a clinical care plan, and we have to focus in on the redesign of those care plans in this work. So on slide 16, you'll see as we level set here at MedDecision to help our customers really optimize and focus in, we wanted to help them be able to predict patients that are high risk of readmission and give them a tool that would allow them to prioritize those patients very quickly. So this is an application that is designed for care managers or navigators to track against a 90-day clinical pathway and quickly and visually be able to identify when their episode of care is off track, and then help them to zero in on where they need to spend the time and getting that patient back on track. And that's really what the application is set up to do. On slide 17, we went through an example here, and this has really been resonating with our teams that are talking with health systems that are about to embark on cardiac bundles especially. So as you look at this and you start to see your bottom line here, even if you focus in on just reducing readmissions, you see clearly that even in a very small program with only 300 episodes of care, in utilizing a tool to help the team, you are quickly able to see a return on investment as you utilize our solution in the Bundled Episode Manager. And then on the last slide, before we open up for questions, I wanted to just give you a snapshot of what the care management teams would have access to help them prioritize their work. And so this is a visual, and it may be a little hard for you to see there, but a visual of how teams could prioritize their patients. This is a patient landing page here, and the content that's feeding this is a clinical care plan. So you have goals, you have actions, and you have barriers that are feeding in and have the ability to be individualized for care managers to create a care pathway and then track to that care pathway and help patients succeed on this 90-day continuum of care. Remembering that your care management teams at a glance need to understand how high is the readmission risk. So we have a LACE score built in here. They need to understand what is the care plan for success for this patient. And so we've given them some clinical content care plans that are specific to the clinical episode to select from. They can also individualize and add things. And then what barriers do your patients face on the journey? And then how can I help them succeed? So that's how the application is set up. And as Margot mentioned in the introduction, our team is available to work and talk through any more details, because it's just a very high-level snapshot of what we offer and wanted to bring to your attention. And then I just call out to you before I turn it over for questions that on the very last slide of this deck that you will receive is all of my contact information and all of the ways that you can reach me or you can reach MedDecision for follow-up information. So with that, I'll turn it over to Scott, and he'll moderate some questions for us.
Thank you, Dr. Cole. We've got a whole number of questions, and I'll start with a handful of them. The first question relates to physician colleagues that are against bundles or have a knee-jerk reaction that they will be, about managing patient risk or having to be involved in this. How do you approach that with physicians to try and knock down some of the roadblocks to acceptance of being part of this?
Yeah, that's a great question, and hence why I started on alignment with physicians, because it will be one of your key challenges as you start to do redesign in this area. So physicians are clinicians, and that's why I included some of the research. There's also additional clinical research out there now being published by their peers. So, for example, if you're in a joint replacement bundle, there are several research articles now that have been published by orthopedic surgeons who are engaged in this work that are saying themselves that the model is valuable, that it helps them improve their practices, and that they are now being able to do the clinical care they always wanted to do. And the hospital is now supporting them to do that care because the hospital is being held accountable in this way. So most physicians truly want to engage patients after surgery or after the hospital admission. They want to have care managers at their fingertips to help with patients. And so it speaks to most physicians. You'll always have some that will require convincing and require evidence. And there is lots of research out there now, so I encourage you to reach out and get some of that research to show them. And there's really research out there now that will show them for pretty much every argument they'll throw at you, you'll be able to find some evidence against that. So,
and how much sort of hand-to-hand individual communications with physicians does it take to sort of get them interested and get them involved? Do you have a feel for that?
Yes, great question. I would say this is a very high-touch program overall. So with the physicians, with your preferred partners, with your patients, with your operation teams, truly, I would tell you, when you start to go down the path of care redesign and bundles, you will spend a lot of time, especially in the beginning, with all of those groups in creating your redesign. So I would definitely encourage you to dedicate a team to this, to dedicate a leader to this work. I didn't mention that in alignment, but it's truly an area we see often is teams that do not designate a leader to do all of that touch, because you will have a lot of high touch in this program to get this launched successfully.
And Tamara, a related question, the aligning your care team, not just your physicians, but how do you get the care team to sort of buy into this when up to this point they've been very focused on volume, and this moves more towards the entire bundle and manage the whole bundle of care and the quality and clinical components as part of that? How do you get beyond the physicians, the rest of the care team engaged and involved in this?
Yeah, that's a great question. I think from my experiences when we start these models of care, the care team are usually the easiest ones to convince. Most clinicians prefer this model because it allows them to actually focus in on what they have always felt is important. So in a volume model, you truly are charged with doing as little as you can in as very short amount of time, so that you can move on to the next patient. So this model is a complete different model where you actually are able to suddenly look at all of the patient's needs and focus in on the entire patient, not just one piece, not just surgery, but the actual entirety of the patient's journey. So this speaks to clinicians. So on your operation teams, you will certainly see your clinicians are going to be excited about this work, and the others will quickly see the results and come along, in my experience, to getting on board with this.
And one other question that relates to physicians versus hospital-led sort of efforts and bundles. Do you expect CMS to prod one way or the other, or they be agnostic whether future models should be led by physicians or hospitals in terms of bundles?
Yeah, that's a great question, and certainly not surprised that someone is asking that. I think we'll see what we've seen in the past. We'll see both. So clearly in the mandatory bundles that have launched so far, Medicare is testing hospital accountability models. remember, in the CMS goal and in the research you just saw me highlight from Medicare, this is a research model, so expect the models to look different. So they tested in the voluntary bundle version 1. They tested a wide variety of accountabilities, and the mandatory bundles narrowed its hospital. I think as we see the next version of voluntary bundles, we will see physician accountability as an option. And so I think we'll see it, swing back to physician accountability, and we saw that in the oncology model that they launched, holding physicians accountable for that. So I think we'll see them embrace all of those different models, again, remembering that they're testing these models so that they can decide which model is the most effective, and that will be the model that we see moving forward.
Let me ask you a question. The technology tools that you referenced for this, how important are those for care teams and physicians to be able to track what's going on and be able to do this successfully?
Yeah, I would definitely encourage teams to think about your technology and tools on day one. Certainly lesson learned. A lot of teams have tried to go at this work with tools they already have at their fingertips, maybe tools we're using today or spreadsheets or sticky notes. This is a much different model as you start to track against a 90-day continuum of care, and you start to build a care pathway that you want your team to focus on. They need a tool to help them do that work. And certainly it doesn't have to be a highly complex or highly expensive tool, but they need a tool that will allow their navigation teams to really zero in on the right patients and then help them be successful on their 90-day journey.
Got it. And another question. We've talked about care time teams and physician alignment in your nursing and operations team. What about patients? How important is it to engage patients in bundled payments and how their care is going to be managed?
Yeah, thank you for that question. It's often overlooked. I would tell you the most successful teams have patients that are part of their care redesign team. So they have that patient voice at the table with them as they redesign care to give them feedback on the patient's perception of how that change would be positive or negative. I would encourage you to include that feedback right away as you're doing this work, and then get their feedback often on the changes you've made. For example, if you implement a pre-operative optimization program, talk to the patients going through the program. Ask them how, what they like about it, what they don't like about it, what was helpful, what was not. So again, remembering this is not static. This is a change model, so you need to continue to get that feedback all along your journey. But patients are that very critical perspective, so great question.
And another question, will Ariel, and excuse my pronunciation, work well with EHRs, or is it a total standalone program? Does it have to be on site? Is it in the cloud? How does the program work with existing technology?
Sure. Glad to talk about that here, and glad to give a lot more detail offline if you'll reach out to. It is a standalone cloud-based solution, so it does not have to have any expensive interfaces for the care teams to utilize it and do their work. So it was designed in that way, so it could be stood up very quickly. It can be utilized by teams wherever they are. So if they're in the hospital, they're out in the community, they can utilize the solution to help them keep track and keep patients on a care path. So we can give more detail on that. It's a great question.
Great. I'm going to ask you a question a different question. The founder of MedDecision is well recognized as one of the brightest people in healthcare. Any thoughts on how Deb Gage and your team got into this area?
Yes, that's a great question. I appreciate that. So certainly MedDecision, and you'll see it on our slide deck. We consider ourselves liberators. We want to be innovators, and we want to work with teams that are in the business of innovation. So certainly as we look at ourselves as a company and in this population health space for over 30 years, as teams, especially now in the provider space, are being given the opportunity to participate in these programs, we wanted to be a partner. So the vision was there by Deb and the leadership team to create solutions that would help teams be successful, and we were able to leverage our evidence-based content that we use for our other full-spectrum solutions in that work. So it definitely requires a visionary, and we have a leadership team that is there and thinking ahead about what teams could need in this space.
You've got a number of questions here that I think are really offline questions. So one of the next questions, which I won't ask you to answer on board because I'm not sure what it is, but it's the pricing of the bundled episode manager. And what I wanted to do on that question is not to have you directly address it online, because I just don't have any idea where that's at personally and don't want to put you on the spot, but I do want to encourage anybody who's on the phone, would you mind, Tamara, providing again your contact information and how people can reach you?
Yes, absolutely. And you should be seeing it up on the screen now, but my email, you're welcome to directly reach out to me at tamara.cole@meddecision.com. Also on LinkedIn, and as I'm talking to you, I see several of you reaching out to connect with me on LinkedIn. Thank you. I'm glad to connect with you. And you can reach out to me in that way as well. But absolutely feel free to email me directly or email the MedDecision team, and we will make sure to get you all the information on the product and the pricing and anything else we can answer for you.
Great. And it's Tamara Cole at meddecision.com.
Yep.
.cole. And Cole is spelled.
And
Cole is spelled. Thank you very much. Thank you. I think, Dr. Cole, we've wrapped up on almost every question. I mean, there's one other question I think is on everybody's mind, but you've answered it partially in a number of different ways. But sort of future versions of CMS bundled payment programs, both current administration changes, are the things that you can expect, what they'll include, what they won't include? Any comments on that?
Yeah, sure. I'd be glad to comment. So I do have the pleasure and opportunity to work closely with Innovation Center, and I know from my connections there and what we're hearing and what we saw recently with them holding firm to the mandatory cardiac bundle launching on July 1st, truly the evidence is out there to support that these programs are working. So we do not see that Medicare will decline in their participation in these programs. I do expect the voluntary program to launch in 2018. Again, I think we'll see a variety of accountability models in that, but I do expect that it will be similar to the first voluntary program, meaning that Medicare will give us an opportunity to select from the clinical episodes of care that we have an interest in. In version 1, there were almost 50 areas that we could select from, so I suspect we'll see a similar number. And I would encourage you as teams to not be afraid to go into the voluntary model. If it's offered up, use that as your opportunity to learn how to be successful in a 90-day model of care, so that as Medicare starts moving toward more mandatory bundles. Now, the new administration is definitely anti-mandatory bundles, but yet we did not see them take it off the table for cardiac. So I think that's a clue that they may tolerate this innovation work with mandatory cardiac bundles. But in the future with this administration, I think it definitely will be more focused on voluntary bundles. I think you'll have the opportunity to participate in a lot of different clinical areas with Medicare in this work and get experience and have less of a downside risk. So definitely expect that to continue on. And then absolutely Medicare has publicly stated that they want to move toward more multi-payer models. So look for more of those type models where you have multiple payers involved. And so I think that will expand also in 2018.
Gotcha. Thank you so much. So I think hopefully, I know we're going to start to lose people as it gets past the hour. you've answered a whole number of the questions that were here and provided a ton of information. So thank you so much. It's always a pleasure for me to get a chance to visit with somebody who's right at the cutting edge of what they do, and your company is certainly there. So Tamara, thank you so much. I know that the PowerPoints will be available for everybody that's on the phone within about a week or two, and then the recording of this will also be archived if other people want to hear it. And probably as important as anything, people can reach MedDecision for help with their own bundled payment programs, and how to manage this and the tools for it through MedDecision and through yourself and others there. So thank you so much.
Thank you very much, Scott. Appreciate it very much.
Great. Margot, we'll wrap up with that, and thank you as well for helping to host this and make this work. Thank you, folks.